I'm a rheumatologist, and we are going to talk about the osteoporosis medications and how they work. To understand the medications, you need to understand what bony remodeling entails. Think of your bone as a building that's constantly being renovated. The osteoclasts are the demolition team. They break down parts of the building that are old and broken down, and the osteoblasts are the construction crew that help build new bone. This is a continuous cycle that needs to happen to maintain skeletal integrity. There are two different kinds of osteoporosis medications. There are anti-resorptive medications that slow down the demolition crew or the osteoclast, and there are medications that speed up the construction crew or the osteoblasts. So anabolic medications speed up construction, and anti-resorptive medications slow down destruction. Generally, you consider an anabolic medication like teriparatide, for example, for one of three reasons. First, if the patient has had a fragility fracture within the last year. Second, if the patient has a T-score that is below -3. And third, if the patient has a very, very high fracture risk, meaning major fracs greater than 30 or hip fracs greater than 4.5%. Otherwise, an anti-resorptive medication is usually used first. Let's talk about the pros and cons of the anti-resorptive medications. Now, pretty much all of the anti-resorptive medications have a very, very small risk of avascular necrosis of the jaw and atypical femoral fractures. If you are interested in that, I have a different video on those particular side effects linked below, but I want to focus specifically on the pros and cons that differentiate one anti-resorptive medication from another. First, alendronate. Pros: cheap, oral, taken once a week, and the effects of it are pretty durable, meaning you can go on drug holiday after a certain amount of time, and usually the effects will continue while on drug holiday. Cons: this can aggravate acid reflux, and you need adequate renal function to use it, usually greater than 35. Risedronate, also cheap, oral, and can be given once a month. Cons: also can aggravate acid reflux, also requires adequate renal function, and the durability, meaning the ability to maintain effect after discontinuation, is kind of less compared to alendronate and zolendronate. Zolendronate, pros: it's IV, given once a year, and it works very well. It can also be used in people who have gastrointestinal intolerance to the oral medications. It's also a very durable drug, meaning the effects will continue to carry over during a drug holiday. Cons: you can get infusion reactions like acute bony pain and flu-like symptoms with the infusions, and it also requires adequate renal function. Ibandronate, huge con is it does not consistently reduce hip and non-vertebral fractures. The last one, denosumab. So this one is an injection given every 6 months, and it has greater bone density gains compared to any of the bisphosphonates. It's also the only anti-resorptive that can be used safely in people with advanced chronic kidney disease. Big con for denosumab is when it is stopped, you can get rapid rebound bone loss and an increased risk of vertebral fractures. So with denosumab, you either have to transition the patient to a bisphosphonate or continue denosumab indefinitely.